All right, we're going to get started here. This is Carol from the STS, and this is the Adult Cardiac Surgery Database monthly webinar for September. I see all my friends here. I have some family up in Appleton, Wisconsin. Hi, Julie. Nice to see you there. And sorry it's raining, Barbara in Connecticut. All right, so happy September. We're just about to start fall, and I'm going to go out and get my mom's next week. I'm not happy about it, but that means that it's going to be Christmas and the winter holiday soon, so that's good. All right, so for today's webinar, we will just do some quick introductions, welcome and introductions, go over some STS important dates, IQVIA update, and then we'll have Ms. Annie Kouchoukos presenting our STS education for this month on utilizing the resource library. Annie hails from Muskegon, Michigan at Mercy. And I watched her presentation on the Michigan Data Managers meeting that was held in August. And it was just so wonderful. I had to ask her to come present on a national level because I think it will be helpful to all of us, including me, to learn a little bit more about the resource library. And then we'll go to open Q&A. Important dates for adult cardiac. Today is September 1st, and we have our monthly webinar happening now. And then September 15th will be our user group call. September 16th is the new data managers webinar. Both of those calls are at 2 p.m. Central. AQO is scheduled for October 12th through the 15th. Adult cardiac will be held on October 14th. Okay. STS updates. Don't forget, if you haven't registered, register for AQO. And I should mention, we already have over 800 folks registered this year. And we still have quite a few more weeks left until AQO. So I'm really looking forward to see the volume of people joining us and just connecting with folks in a little bit different way than we normally do virtually with this AQO meeting. Harvest 2 reports have been posted. Internal discussions at STS have resulted in notifications to be sent out for upcoming releases. So we did not send a generalized notification out regarding the Harvest 2 report. The notification was posted on the IQVIA in the IQVIA platform under the notifications tabs. But going forward, we will be sending out we will be sending out specific notifications regarding upcoming report releases. And then Harvest 3 data is in analysis at the Analytics Center. So we should expect that back hopefully I think it's Harvest 3. So sometimes it takes 6 weeks to run the analysis on that. And then IQVIA a couple more weeks to QC the data before uploading it. After they upload it into the platform, they do some QCing to make sure it's all transferring over correctly and things are looking good, and that might take a week or two usually, but more definite timelines will be provided in the near future. Molly says hi. Okay, now I'm going to hand it over to Joe Brower for the IQVIA update. Joe?
Great, thank you, Carol, and good afternoon, everybody. Just a few items from me, starting with something that we put in last weekend on the 28th. There was a general platform update over the weekend, and you should no longer need to choose the case form option from the drop-down menu in the upper left when you submit your files. So that should default to case form for you. So you can, that step will not be something you need to do anymore. Next slide. We don't have a release date for our next release yet, but we do have some known issues that we are targeting for that upcoming release. Starting with the participant dashboard report, STS 6485. We have received feedback regarding how the post-operative stroke data is displayed on the participant dashboard, and we are looking into ways to reconcile the yes response from the 2.9 version with the various yes responses that are available for the version 4.20.2 form. So that's something that we are working on, and we should have updates for you in the near future. STS 6747, some percentages displayed on the participant dashboard appear differently on the web page versus that same data when you export it to the spreadsheet. So we are looking into that. We believe we've identified what's causing that, and we're working to get a fix out to you as soon as possible. STS 7193. The total post-op ventilation hours is displaying as missing when the extubated in OR variable is answered as NA. And that should not be calculating as missing, so we are working to get that fixed. In the meantime, since it's incorrectly flagged, you can disregard that if that comes up on your report. And then STS 7152, the dashboard is not correctly displaying the counts for patients marked as expired in OR, in that the MT OpD died in hospital plus died in OR line on the report. So we are working to get it fixed so that those patients are correctly included. On the risk-adjusted report, STS 6785, the NQF outcomes measures are displayed as a percentage, and it should be displayed as a ratio. So we're working to get that corrected. And STS 7183, the calculation for blood products used is incorrectly referencing the archived patient variable for intra-op blood products refused. So that will be corrected in an upcoming release. Regarding the missing variable report, STS 6781, we are looking into reports that the NQF variables filter on the missing variable report is not correctly including the variables it should be. So we're looking into which ones should be included there and getting that updated so that they do work correctly when you select that filter. Also on the missing variable report, STS 6832, similar to 7193 above, the total post-op vent hours are displaying as missing when extubated in OR is answered NA, and that should not calculate as missing. So disregard that if you're seeing that, and we will get that corrected soon. And finally, STS 7194, the MVR is not flagging surgical site infection as missing when it is missing. So we are working to get that fixed for you as well. And that, I believe, does it for me. The usual reminders that we do have the list of known issues available posted for you in the library. So feel free to reference the library for that information. And if you do have tickets that we did not discuss on today's call, feel free to respond to those tickets and request an update from our team. We're happy to do that for you. And we are continuing to look into items that have been reported, so please keep an eye out for more information. All right, and that does it for me.
Wonderful, thank you, Joe. And I just wanted to add, if you don't mind, I know one is an investigation. I don't think you have an STS. You probably might not have it because I just brought it to Melanie yesterday, and it was that the pneumonia was missing in the non-analyzed dashboard. The pneumonia counts were missing. So I just, so for those who are aware that is being checked out, I think Heidi had brought that to our attention yesterday.
Yeah, and I hadn't seen it yet, but thank you,
Yeah,
Carol.
it probably hasn't made it your way yet. I just wanted to mention it. Thank you, Joe.
Great.
Yeah,
Yep.
and I was looking at all the, so here's the IQVIA is going to post an update with the full list of known issues and enhancements to the library for user reference this week. And when you submit your tickets, remember to include your participant ID number. And if you are contacting IQVIA about an open ticket, be sure to include that ticket number. I can't make the screen any, I see somebody asking if I can make the screen any bigger. I can't make the screen any bigger. You just might have to maximize it somehow on your Zoom account there. And then the IQVIA support plan, which we're all pretty familiar with. Okay. Now I'm going to hand it over to Ms. Annie Kouchoukos from Mercy Health in Muskegon. Annie presented at the Michigan Collaborative Data Managers meeting earlier in August. I saw her presentation regarding the Exploring the IQVIA Resource Library, and I thought that this was something that should be shared nationally. So I invited her to come speak with you all. I'm going to hand this over now. To Annie. Annie, thank you so much for joining us today, and the floor is all yours.
Thanks for having me. Hello from Michigan. So my presentation is entitled Exploring the IQVIA Resource Library, and I am a data manager at Mercy Health Muskegon, which is in Michigan. I do open heart, and I'm newly starting thoracic abstraction and data reporting for my hospital. And I have no disclosures. It's disappointing to me too. In IQVIA, does anyone else beeline directly to data submission and you're pretty much blind to everything else? That's kind of how I've been, because it's kind of been a rocky road getting started with our new data warehouse, and that team is working really hard, but it's kind of like a wait, I think I see pavement. So let's explore a little. And I'm going to toggle between this presentation and the actual IQVIA login screen. So when you first log in, I have two sites to pick from. And if I click, this is the beeline directly for data submission. But if you scroll down on the left-hand side here, there are some things, including the library. And you can see a lot of different resources. And like it says, many options. But the couple that I wanted to look at are the National Report Analysis Overview. So that's the very first one. And when you click on these, they download as documents. So it's over here. Let me open it up. I'm happy this is going smoothly. So some of the things that I found interesting in here are things that you're asked a lot by your surgeons, like what's a like group? What does that mean? So you can use your search feature in here like this. And here on page 5, it says here are what the definitions of like groups are. And so it goes by volume, and it does do different for CAV and different for valve. So next time your surgeon asks, same thing with regions. What's a region? That's on page 7. You can also navigate here. So I, being in Michigan, I'm here in the Great Lakes region. So when your surgeon says, yeah, what exactly does that mean? These are the states that are in there. Then you get some basic explanations of stats. I don't know about you, but stats was pretty good for me. I know a lot of my fellow nursing students struggled, but on page 10, it starts with some just kind of overview, a good old mean, median, and mode. What does that mean? Those probably got, but 25th percentile, what does that mean? So there's a little reference there. And then also risk adjustment. So what does that look like? How do they risk adjust? Some explanations. I have actually shared some of these pages directly with my surgeon when he asks. I'm pretty sure his mathematical ability is much higher than mine. But it also does go into some of the richer detail, like predicted risk, O to E, things that you kind of hear in some of these presentations, and you're like, what? What's the skinny on that? So that starts on page 19. And I find this helpful even as an experienced data manager. You kind of get the lay of the land initially, and then what can I do to generate better data or share and understand what I'm presenting better. So that is helpful. And also it does include some inclusion and exclusion criteria for common metrics. So that's always a good quickie to have. What page was that? That was on page 7 again. So inclusion and exclusion, and it spills onto this very nice table. So some of the common ones, like let's say re-op, who's in re-op? This is re-ops, and it goes through what's included. Or what's that nuance at AFib? Those aren't the people, like it excludes people with a history of AFib. So some of these, as you get more familiar, if you're new, you'll kind of start memorizing some of these, but also it's good to know where's your resource for understanding those. What else? Risk model definitions. So renal failure, for example. This is again in a really beautiful table format. So renal failure, it goes through all the different criteria that are in there. For example, or what's prolonged vent? Deep sternal wound infection, and it kind of goes through the logic there, which is cool. And what else? STS composite and star ratings. Those are always a hot item with the surgeons. So it goes in how it's calculated, and get ready for some deep reading on this. You know, this is not a skim it because it is pretty complicated, but it's good to have there. I would review that right before you share your star ratings with your surgeon. And it does in this table here on page 30 have kind of the skinny version. So that is nice to have. And then NQF measures, the National Quality Forum measures, starting on page 38. So it goes through the different categories of process measures and outcomes measures and describes how they're calculated and displayed. So that is technical. What else? So when your surgeon asks, how did we stack up after those composite ratings are shared? So if I can get myself back to the resource library here, hold on. Ooh, it's hard with all these different meeting screens showing. So if you choose this document with the composite ratings, and I'll choose this 2021 document, and again, it goes to my downloads. And this. Yeah, so this is just a one pager. I say unveil the mystery. This just in one page describes how many hospitals or sites there were that participated, that submitted data for that composite rating. Because as you remember, Carol saying that they only calculate those as one moment in time. So at the data submission for the period ending December 31st, it was 917. And it goes through, especially at this table at the bottom, who got what. My site is probably in the middle here for most of our metrics with the bulk of the several hundred sites, but there are some rock stars, like 53 sites got 3 stars on isolated cab. And so you can kind of help your surgeon understand how our site stacks up, which is really nice. Any other perfectionists out there? My data can never be too clean. That's how I feel. Well, work smarter, not harder. So this one I pre-downloaded in advance because it takes a little bit, but the errors and warnings document is really neat because it lists what generates a warning, an error, or a critical error in our current and the last 2 database versions. And so I've kind of doctored this Excel file up a little bit so that I could hone into some examples. But at the bottom, you'll see all of the different versions. And so we're in 4.2. So what generates critical errors? And I highlighted one where it's OR exit time. Like if you fat fingered it while you were typing and the OR exit date was before the skin incision stop date, then it will kind of clue you in and say that's probably not right. And the other nice thing is that not only does it include what the error message would be, but scroll a little far, it includes what the logic is. So how you, like I highlighted it, so it's the short sequence names. So you'll have to do a little bit of digging through your training manual to look, but it'll help you figure out if I get this error message, where are the specific fields that I need to go back to and change. So I find that really helpful because sometimes I know kind of intuitively what feeds into something, but other times I'm at a loss. How do I fix it? So that could help you tune in. So the logic is really the highlight. And other examples I honed in on, there's one for renal failure. So Melinda was mentioning, reminding us that if you had preoperative renal failure with dialysis before you had surgery, then you can't also have renal failure after surgery. Clinically, you're in renal failure, but you're not going to get the demerit in our database because you already had it. So this will trigger an error warning if you marked both of them, pre-op and post-op, yes. And then it'll go through over here in the logic what needs to be corrected. And then in the warning section, this is one that that I'm always really careful of. I had one quarter where I did something like this error message. My patient was discharged alive. They died after discharge, but my error was that they had died on like day 35, and I still counted it, yes, as an operative mortality, which so I kind of gave us a demerit when we didn't deserve it. And my surgeon wasn't super happy about extra claiming of death. So I'm always real careful to check my logic on these, and these error warnings can definitely help you out. So it also kind of, it helps me clue in. There are some things that I feel like I commonly make errors on, and I have spent time as a data manager building some of my own logic through my software. I'll pick out certain fields and check that I didn't mark two things as yes that shouldn't be paired together. So it told me some of these that I could take off of my manual querying list. So I think that's really cool. So I think you should try it on your own. See what's in this resource library and let me know if you find anything cool, because I think there's really a lot on there. So,
Wonderful. Thank you, Annie. Before you stop sharing your screen, can you please show folks how you got to the resource library, and just do a quick run through again of just pointing out which resources you just shared with us?
Definitely. So when you log in after you select the database, if you have multiple, this is kind of where it lands automatically on the upload screen. And on this left-hand menu, you scroll down a little bit and you get to the library. And these are all the different documents that are available. I discussed this first one, these two, and then this errors and warnings. And I know that, Carol, you mentioned this known issues and enhancement list that the IQVIA team is going to update that soon. That's always nice to have a reference of as well. I didn't specifically highlight that, but I will now. So there's a lot there. And if you're a newer data manager, there are some teaching tools as well, like like this missing variable report. It goes through how to access it and what you should be looking for. So it's pretty cool.
It is cool. Thank you so much. That was just a wonderful presentation, Annie. I really appreciate you coming and sharing that with us, and I'm looking forward to the future presentations we can have you on for.
Thanks for having me.
Yeah, thank you. I'm going to take over the screen back over. Thank you. Okay. And thank you so much, Annie, in the Q&A. This is so helpful, and well done again, Annie K. So good job. Okay. Resources. Resources are located STS National Database page, STS National Database feedback form, and IQVIA telephone support, as well as my email, ccrone@sts.org, and database operational questions, stsdb@sts.org. It's time for Q&A. We've only gone into this a half an hour, so I do have an update. And thank you, Beth, for that question. So Beth is saying suggestion for the new version, label on the aorta section is currently titled aortic, and it would it would read better and be more clear if it says aorta. So first I want to thank you for the suggestion, Beth, and we go back and forth between aortic and aorta, kind of synonymous with each other, but I certainly understand what you're saying there. We had just got word earlier this week that because of all the changes, because of the version 4.2 upgrade and how successful that was, to find minor issues with a few parent-child relationships, but nothing major, and it was a very big upgrade. The surgeon leadership at STS feels that we are set for another year or two regarding upgrades, so we will not be undergoing an upgrade for adult cardiac. Other changes are happening within STS, more news to come on that in the future, but for right now, we're not performing an upgrade for 2023. So it's kind of good news, kind of, we'll see how it goes. Hopefully that it's a good decision, and it works in everybody's favor. So I just wanted to share that with you. But please, those types of suggestions, Beth, that you just sent in, please continue to send them to me because I'll keep them in my my file for whenever the next upgrade happens. Okay, thank you. And then great presentation. I don't think I've ever been able to build a detailed error and warning spreadsheet. How did she build that? So I think that, Annie, that's, you pulled that directly from the IQVIA platform, right?
I did. I downloaded it in advance of the webinar because it takes, I don't know, 30 seconds or a minute because it's such a big file. But
Yeah.
yes, it is in the library, and I'm guessing that the IQVIA team will periodically update it because this one is dated June. But yep, I did not build that. It's all them.
We, so I thank you. So IQVIA and STS, we did this together, and this is what STS provided to IQVIA when they're building the errors and warnings and critical errors out. And then we worked through it with IQVIA to come up, make sure the logic was correct within it. And it's this errors and warnings updated document. It comes down as a Excel spreadsheet. Like Annie said, it takes a little bit to load, but it has all the logic in there and what the message will read and things like that. So thank you for educating on that. That's very helpful. Okay. Next, this is a random question, but why is the EVH times not documented in the harvest? What's EVM? What's EVH times? I must not.
Saphenous vein harvest time.
Oh. Are we still collecting that?
Yes, we collect it.
We almost removed it. The reason we didn't remove it is because I think they were looking at it for RUC for
Utilization.
Yeah, for utilization. And we almost did remove it in this version. That's why I questioned if we were still collecting it. No, sites do collect that, but we're not reporting it out because we don't, wasn't much, I don't think it was being used very much. And that was a decision made. But Shelley, if you think that that's something that should still be reported out, please just send in an email and we'll put it on an elaboration call with IQVIA and discuss it. Resource utilization something. Thanks, Melinda. I'm like, what? I knew it was RUC. I couldn't remember what the letter stood for. Okay. Judy says, would STS ever considering working with IQVIA to change some of the warnings for pulmonary artery pressure, all the pressures, because our patients are not typical patients. They tend to be outside the normal of these a lot, and we get hundreds of warnings each submission. I definitely think getting rid of the duplicate patient warning would save us a ton of warnings. I know this might be possible, but I thought I would ask. So thanks, Judy. Actually, the surgeons are the ones who set the warning levels for all of these fields. So they set the warning levels to a normal range, and it's just a notification. I certainly understand what you're talking about. But remember, I think I had mentioned before, it's really easy to filter. I'll go into another fake site here. It's really easy to filter when you're looking at your warnings to see if you even really need to pay attention to those. Let me see if I can find that again. I think it's like your harvest summary report, right? So, and maybe this site will have some warnings. I don't know if we have any in here or not. I will just give it a second to load. Yeah, so we have some warnings. So if I just click on the green box here, is this where I want to be? I don't think this is where I want to be. Hold on. No, I think that was it.
Isn't it the missing variable report? Or no, it's the harvest summary report with all these warnings.
Yeah, I
Right?
thought, yeah, I think so, but I don't know why they didn't pop up when I just clicked on that. So let's try it again. There's an easy way to filter on those. So if if you're aware that most of those are out of range, you can just kind of skip over them. Let's see if that's gonna do anything for me. Oh, because I have to click on warnings. Okay, so when I click on the blue thing, that's the warnings, and I just move my mouse over here. I see this double arrow. I make the screen bigger. I right click or is it, why is it going to give me a hard time? Left click on message, and I just sort them by the arrows, and I can see all of these warnings. They automatically put them in alphabetical order, and I just want to scroll through here just to see. I know that I can probably skip. I'm going to double check these bypass times, but in cross clamp times, I'm probably going to double check. But when I get down to the pressures, knowingly, these pressures are probably going to be out of ranges, especially if you're doing very sick patients. So it's okay to skip over them. I think it's, it's not useful. I agree that it's not helpful to have warnings that just pop up for all the patients. So it is something that we should take back to the surgeons and discuss it for whenever we do an upgrade to see if there's, maybe we can make those ranges a little bit wider so that these warnings are actually helpful to you when cleaning up the data. But just in the meantime, the way to do that was I left clicked on message, I sorted, and then was able to easily scroll through there. But yeah, I agree. What's the use of a ton of warnings if you don't do anything with them? Okay. Judy says, do you know if STS is creating AKI risk reduction after cardiac surgery? And if so, do you know when it might be released? I'm not familiar with that, Judy. I think Scott Firestone, and I don't know if Leanne's able to, or one of my STS colleagues is able to put Scott's email in the in the chat
Yep, I've
box
got it,
for
Carol.
you. Thanks, Leanne. I just reach out to Scott Firestone. He's usually the one who handles those for us. How do the fixes within the platform that are found after harvest period reflect our overall data? So I think I'm gonna go back to Joe's slides here. So we had a couple of things. The participant dashboard is non-analyzed data, so that doesn't impact your data other than you just didn't have this information prior to the harvest close in the platform, but you still should have had it within your vendor's software. The risk adjusted reports, these two that Joe talked about, NQF's showing a percentage sign when it should be a ratio. They're going to remove that percentage sign, so there's no change in your data there. And then blood products used to calculation updated required to move archived parent variable from previous child variables. So they're going to update the mapping. That was a raw number, so that data may change in your analyzed reports. Missing variable report is a pre-harvest, a pre-analytic report that you use. So this does not impact your analysis other than notification of these issues, which should also be available within your vendor software. I hope that helped, Anita. Okay, if you know the valve explant name, but not the specific model number, should we say no to sequence 3330 explant device known? I'm going to let Melinda, I'm going to let you take that one. I think it's pretty important that we get the model number on for that patient. And sometimes it takes a little bit of digging or even contacting Edwards with the patient's name, because they all get their valve cards, their implant cards. And it's a lot of work though, and it shouldn't be falling on the data manager to do that. But Melinda, what do you think on that one?
Well, I'm looking at what 3300 is exactly, what that question is.
Okay. I'll let you look it up. I'm going to go to the next one.
Go to the next one. Let me look this one up.
Okay. Barb Sanders says PID 30668, looking for an update on STS 7076. And Joe, are you able to provide an update on that, or would you?
I'm looking into it. I'll type an answer back to Barb once I find it. I'm having trouble finding it right now, but it will come
Okay.
up and I'll provide an answer.
Okay. I'm going to go to the next one. And Barb, I'm going to ask you to please send your question. Barb asked a question about a conversion for a thoracoscopic atrial appendage clip in conjunction with the subxiphoid convergent procedure. Barb, I'm going to ask you to please submit that question into the FAQ mailbox so Melinda can review it and make sure she has able to provide you with a clear answer back.
Okay, so I'm gonna go back to Amy's question.
Okay, Amy said, if you know the valve explant name, but not the specific model number, should we say no to explant device known, or should we pick one that say, i.e. Edwards Paramount?
Well, and when I'm looking at this data collection form, because I'm not looking at the spec, so it has explant model number. So, I mean, I don't think there's a way on the selection set to pick a device without knowing the model number. But I'm not 100% sure on that because each vendor seems to have different little special ways that they have designed their selection sets, should I say. They all look a little different. So the question in of itself is, first of all, I think it's important that you try to find that information if you can. That's important, as Carol mentioned. But if you can't find that information, Carol, what do you think? I mean, you could say you don't know it because it's simple when you look at the data collection form. It's whether you know what the model number is or not.
Yeah. I agree. I think the question is it known or not? And if you don't know it, you don't know it.
Right.
But I think it's really important to try to get that because that's for longitudinal device surveillance. And we don't know if products are good for patients or not if we don't know, how long they're lasting and things like that. So it's important to get that. You could choose, I don't know if that's big enough or not. For explant position and explant type, you can still capture that information, the explant etiology. So this is enough general information, I think, to capture. If you don't know it, I would just code no if you don't know the model number or the UDI in that. Hopefully it doesn't happen too often. Okay, I see some hands raised, so I'm going to go over there and see if I can see if you really want to talk to me. Oh, it's Amy. Okay. Oh, somebody brought it. Did I bring Amy over? Somebody brought Amy over to our side. Hi, Amy.
Hi, can you hear me?
Yep. How are you?
Good. Yeah, so thank you. When we take valves out, often you look at an old op note and it may be a very general statement about the valve that, it was an Edwards Paramount valve in the aortic position. But what we have Lumetics as our vendor. And when you get to that field for the device model number, it's the giant list of valve names, the same list that you do for implants. And so, there's a Paramount with, this, anyway, the list is very big. And what we've been doing is we've been just kind of picking one because I thought maybe people wanted to know sort of in general what valves we're taking out. But because the list is so big and specific, then I thought, well, maybe we shouldn't be doing that.
Yeah, I would not just be picking one. The patients, there should be documentation in the previous chart. Usually there's a sticker. That's why I'm Googling stickers. Usually there's a sticker that it's usually placed in two spots. It's placed on the implant list from that previous surgery, and that's kept with the surgical record from the previous surgery. And it's also placed, right, because they use that for billing and things like that. It's also placed on the patient. There's a patient ID card, which I'm sure you're very aware of. And I've even had to go as far, I had a St. Jude that a patient that had a St. Jude that I couldn't find. I had to go as far as calling St. Jude to get the patient's model number for their valve. So it shouldn't be, and I'll pull up the valve list real quick here. I think it might help to show what we're talking about. We don't want to have, I don't think, assume like if they say, oh, patient had an previous Edwards valve, I don't think it's okay just to code just the some Edwards valve with it. I think we want to be as specific as possible, because when industry looks at that data, because they use our data for additional studies on their devices, we want to make sure we can give them the right information for those. But I'll show you, I think it's under device specifications. So it's this long list here. And can you all see that? So let's say that it's a Medtronic pivot aortic valve graft. Or I don't even know if that would be one that they would use, but
There's all
There's-
those Paramount,
there's
there's all those
Paramount.
Paramount, Magna, you don't know
yeah.
which one it would be. There's some with the,
And it's gonna, the way you're gonna find that is on that sticker, the valve sticker. So it's
Okay.
either gonna be, and that form usually comes out of the operating room. And I don't know if now they're being scanned in. It used to just be paper, but that, that was a few years ago. But that form that sticker is usually stuck. The same thing like when they do a cath and what stents they're putting in, they stick those stickers all over the place so you know what they inserted into the patient. So it
Right.
should be somewhere, or it should be on the patient's device card that they were given. That's hard though. So
okay.
and I appreciate the question, because I think a lot of people probably struggle with that.
Yeah. Okay. Thank you so much.
Thanks, Amy.
Hey, Carol, this is Annie. I was wondering, I'm noticing in the Q&A in the chat that I'm maybe caused slight confusion for some people. There is a difference between the errors and warnings report that I highlighted and an actual data quality report for what you've submitted specific to your site. So what I went over, the errors and warnings report lists out all of the potential errors and how they are generated for the system. So what STS is capable of checking. And if you are actually wanting to see errors specific to your data, then you have to go, after you upload your data, you would go to your, in the upload center, there's a view reports link, and then your data quality report lists the specific errors, and that's where people are going to find their specific patient ID, record ID. So just to clarify that there is a difference there.
Wonderful. Thanks for clarifying. Lots of information going around. Okay. Can you please talk about the email that was sent out about upcoming composite ratings for multi-procedural categories? When will this start? 3 years of data. Thank you. I do not have any more information on that. I think probably the best resource would be to reach out to the STSDB@sts.org, this email here with those questions. I do not know when that's coming out. I apologize. There is no case counts in the risk adjusted reports, only for region cases. Why is it not included so I can benchmark reports? So there are case counts here. I'll show you where they're at. We'll go into the risk adjusted dashboard reports, and I'm just going to pick the most recent one. And Sometimes I think the dashboard changed between times when I opened it last and the new time. And then I go to show you where things are at and then they disappear. But the same thing happened when Heidi asked me the question with ventilation. I could have sworn that it was there and Donna could have sworn. And then when we went into the report, we're like, where did it go? So, okay, so we're looking at the risk adjusted and regional outcomes, isolated cabbage. Oh, you're looking for an N here. Yeah, there's no N. And I don't think we've ever reported out an N here before. I have to double check on that. But under the benchmark section is where you'll find, I think this is where you're going to find your case count. So I'm in the benchmark. Sorry, my mouse is being bad. I'm in the benchmark section, and here you can see the number of cases. This is isolated cabbage, demographics, and these are the number of cases that were taken into consideration for this report. It would be nice to have the ends located on the risk adjusted so you could see what the ends were. And I think that's it's up for discussion with one of the upcoming elaborations. So we are talking to IQVIA about that. Thanks, Julia. So I think, so it's going to be under the benchmarked reports. Will there be information about the following upcoming changes, including aortic risk model, measure, new frailty indicator, failure to rescue, and the cabbage multi-procedural composite prior to AQO? I think the presentation at AQO was going to be the big presentation on those models. But again, reach out to STSDB@sts.org for more information for those. Thank you. Vendor can always tell you the explant. I did it quite often. It's mostly an issue with explant from previous surgery. Yeah, the tricky part is when it's a previous surgery. And sometimes especially if those valves are quite old and who knows where the previous app notes are, or if they're coming from you from different state or something, it's difficult to always find that information. I'm going to go over here. Carrie has her hand up. Sorry, Carrie. I apologize. You could go ahead if you have a question for us.
No, I might have hit it by accident. Sorry.
Oh, that's okay. Thank you. Okay. Oopsie. Heidi, let's see. Heidi, are you there? You just have to unmute yourself. Okay. Next question. When entering the time for perfusion cross-clamp, can we round the numbers? I don't think you're supposed to be rounding numbers. I don't think we round numbers for anything in the database. Melinda, what are your thoughts on that?
I'm sorry, I was trying to unmute myself. Yeah, we're not rounding numbers, so I don't know the specifications for the minutes on that field. I don't have my software specifications pulled up for that field. Field number, where's that number at here? Would be
Right here. It's an integer, so it's a whole number. So you just enter so for example, for 5447, you're just going to enter 54.
right. Yep. There we go. Thanks,
Yeah.
Carol. You're Johnny on the spot with that data specs.
I got my find feature. When abstracting the cath section, if a patient has, I think we're going to have to go, if you have any questions related to abstraction for clinical questions, it's probably better if we enter those in, if you can enter those into the FAQ mailbox, because sometimes Melinda and I we may need to discuss things. There might be an issue where we might have to go to the surgeon. So Cheryl, if you could please submit that to Melinda in the FAQ mailbox, we'll be happy to, she'll be happy to address it. When I say we, I mean Melinda. But we work together. Okay. For sequence 545, just a suggestion from Danielle that we enter lateral, we provide for carotid stenosis and laterality unknown. I think it's important that if you're taking your patients to surgery, that you would probably know where they had some type of stenosis, where it's located at and which side. But I can definitely put that into the suggestion box. Danielle, if you'd like to email me that suggestion, I'll put it over into the folder. Yeah, you have to do your best to try to get it. Otherwise, you're going to have to, you could call the manufacturer. Lisa saying if it's done at a different hospital, we don't have a sticker, or if it's an old surgery, it wouldn't be in the EMR. So an option, like I said, I have had to call St. Jude to even get the information on a patient. So the industry partners, they'll help you out because they also want that information on their patients, and they usually have a direct line for these types of requests. So that's another option. I don't think if we have the explant model available in the record, we don't have it. I don't know many abstractors who have time to go to the extra mile to try to find the information. So if you don't have it, you don't have it. You just say no to that field, right? I know Heidi. Oh, Heidi, are you there? I see you're unmuted, but I don't hear you talking. Okay, I'm gonna go to the next. Oh,
Carol, it looks like she has a second login with her last name included with the hand also raised. Maybe that she's logged in twice.
Or it's two Heidis. Let's see.
Hi, do I have a voice?
Yes,
Yep.
now are you the other Heidi too, Heidi?
No, there's 3 Heidis on today. I do have it up on my laptop, but it wouldn't give me access to use my mic. So then I came in on my phone. So thanks for working with me on that. So Joe and I have kind of been discussing in here something that I came across. So I'll try and break this down simply. One of the fields I was looking at in complications was GI event. And so just to make the sake of numbers easy, let's say there's 350 patients in my N, and let's say 10 had a GI event. So my yes, no's, and my missing is 0 on the non-analyzed dashboard, but the summation of my numbers presented on the dashboard is not coming up to my total population of 350. So what it's showing is like 150, let's say, patients were selected yes for the parent field of post-op comps. And then I've got my 10 who had yes for GI event. My 150 and my 10 is not coming up to my total 350 population.
Hey Heidi, which report are you on? Sorry, I want to pull it up.
Non-analyzed. Yeah.
The participant dashboard.
Correct.
Okay.
And so as I understand it from my conversation with Joe via text, which can kind of get confusing, I think, for people if others are trying to follow what him and I are discussing, is that, so I went to present some of these numbers off this dashboard to our leadership, and they're like, your yes, no's, and your missings don't calculate to your total number of patient population. And then it was confusing to try and present to them and then represent why it was only 150 and 10 and not 350 and 10. And when you crunch the numbers, the value does come out to the correct percentile, but my numbers aren't matching up. Let me see if I can make it bigger on my screen so I can see where you're at. So like, what's your total population on whatever site you're looking at? Is this like a test site, Carol?
Let's see.
So your total number of cases is 246.
So the reason why you might have a difference because what we're reporting out, I think it's not looking at the total N, it's looking at the number of patients who had complications. So
Correct.
You're not going to see this total number in your complications section. You're only going to see the total number. I believe that's probably what's going on, is you're only going to see the number of cases. So you have a total number here, but not all of these patients had
Correct.
Up the parent of post-op complication. So your denominator becomes less, your N becomes less.
But
right?
wouldn't our N always be our total population? I mean, if you're trying to say, let's say prolonged vent.
I don't think that's what, yeah, I don't know. I think we've gone back and forth on that, and I think we probably have to check it out, because neither way is wrong to report it. Reporting it both ways is correct, right? You could look at it as your total population of what number of cases had complications for your total population, or you could look at it as the number of patients who had complications, what was the patients that went into those complications. So, and we've reported it out both ways in the past.
Mhm.
So I think we probably, and Joe, did you have something to add to that?
No, you explained it perfectly. You took the
Yeah.
words out of my mouth. It was perfect.
Yeah, I think we probably just need to go back and probably clarify what this N is, because when we say number of cases, this N is matching the N at, this N is matching the N, and I can see that 242 patients did not have a surgical site infection, and I can see 3 did, and 1 was not, 3 did, and 4 did, and 1 of those 4 was non-infectious. So
Right.
that equals 246, but it might be different for the other field.
Right. And that's where I'm confused. And then when they pose the question to me, they're like, why did our N change? And I kind of
Yeah.
felt stupid sitting there in front of them initially, trying to figure out, I don't have an answer for you.
Yeah,
But
you
when
might
I
have to-
calculated the numbers, and then took my number of patients for whichever said complication and plugged it against the N, my overall population, the statistical value was accurate. And then if you're trying to screenshot that, say for like a PowerPoint or to shoot off in an email, then you're putting your N up above and saying, here's our total population and here's the statistical outcome for a complication. It does look awkward.
Yeah, and I agree. And I think, and then like if you look here, like these re-op for bleeding, re-op for
Yeah.
valve dysfunction, MI, reintervention, cardiac
Exactly.
reasons, these all, and this one is not used, but these that I just said, these are used in the NQF measure for return to OR. So, and this might be where we're looking at a different N, and I think we have to go back to IQVIA and see what's, because we went back and forth on these with IQVIA when the reports were being built. So I think it's important, and we should just be consistent and provide information about what's going into each of these.
Yeah.
Because the end keeps changing, right? So
And it's really hard to present that. I mean, look at your AFib, your summation there is going to be, I can't read it. You just,
it's 90. It's
Yeah.
90. But
You
yeah,
know,
all of these other ones are 90, right? But then when we get up here, when we look at surgical site infections, it's a different end. So yeah,
Right.
good point. We'll take it back and look at it.
Okay.
Thanks,
Thanks.
Heidi. Alrighty, bye.
Bye.
Okay. Sandy, are you there? You might have to unmute yourself. I'm going to try to get to our people with our hands up. Okay, I'm going to go to Lori. Lori, are you there?
Yeah. Hey, Carol. So
Hi.
I found this issue early on because I do direct into IQVIA, and I think there's a ticket out there for this. What the issue is, if you mark no, like when you go to that post-operative complication and there is none, you mark no, and it doesn't fill that no into the total number of people. So to try this out, I went into one that was no complications and went through and opened it up and said yes. And then I went through and marked everything no, and then that corrected my total. I don't do that right now because it's not something I look at every day. But, I had asked them, could they fix that? And there was supposed to be a ticket out there to help with that issue. And this is
And
probably about a year ago.
which field are you looking at? Are you looking at this 6750 other? And I
Yes.
bet you that this is where that 90, when the site,
Yes.
the results I just showed, it's this 90 is the yes that's making up that denominator.
Yes. So
Yeah.
I think a simple fix would be if they could map that no, if there was not any other complications, and map that no and make everything automatically go no. But it's not
Mhm.
even including those as no's at
Yeah.
this point.
And it can, like I said, I know what you're saying, and it can be reported out either way, right? Any out of those patients who had post-op complications, what was the percentage of patients who had aortic reintervention? Or it could be and neither way is wrong. Or it could be reported out of everybody who had an isolated cab, how many had to have aortic reinterventions.
Yeah,
So,
and I see both ways, but I think
yeah.
like Heidi said in presenting it, it's just so much cleaner to do
Yeah.
it to include everybody.
Yeah, thank you for clarifying it. We'll bring it back and talk about it. And And I think we brought it to the surgeons at 1.2, and I don't know, we must have landed somewhere, but we'll bring it back and discuss and figure out a cleaner way to present that. So thank you. Okay. Debbie, are you there? And okay, how about Joe? Are you there? Anybody? Debbie or Joe? Okay. We're 2 minutes. Oh, Pam, are you there? Okay. We got 2 minutes. We're 2 minutes over. So yeah, so Jared asked, can IQVIA add a filtering function on the web port? Yes, there is a filtering function for warnings and errors. So when you open that report, you're going to see that pie chart that I showed you in the harvest summary report. And from that pie chart, you can just select warnings or errors or everything. So you should be able to do that. And you should be able to filter within the report. If it's everything, you should be able to filter within the report by sorting. Really quick, we have a job. Oh, Heidi's hiring. Anybody interested? But don't do that to me, because then I'm gonna have to promote everybody's job, Heidi. So be careful. Can I document the cardiac rehab referral? Okay, so please submit. It's okay, Heidi. Please submit any questions, clinical questions, to the FAQ mailbox. And I agree, Linda, with your comment about providing a sentence explaining what's going into each of the numerators and denominators. So we'll work on that with IQVIA. Thank you. And okay, one more hand raised. Linda or Pam, are you there? You might have to unmute yourself if you want to chit chat with me. Okay. All right. Well, I guess that's it. Annie, thank you so much for joining us today and presenting. Go Michigan. And thank you, Melinda, and thank you, my STS team. Thank you, IQVIA team, Joe, Steve, and Jean. And I wish you all a very, very happy rest of the day. And I'll put up the updates here for our next meeting. Our next webinar is the user group call on September 15th at 2 p.m. Central. So thanks everybody for joining. I hope you have a great rest of the day, and we'll see you all soon. And take care, especially if you're in the smoky or rainy or soaking wet areas. Be sure to take care of yourselves and be safe. Thanks again, and have a great day all. Bye.
Bye, Carol.
Bye. Thanks, Annie.
Bye, Carol. Bye.
Bye, Melinda. Thank you.
Thanks, guys.
Thanks, Leanne.